So at this time, let me introduce our next speaker, Dr. Brian Walitt. Dr. Walitt is a board-certified rheumatologist and senior investigator at the National Institutes of Health. He currently works for the National Institute of Neurological Diseases and Stroke, where he is currently working with patients with myalgic encephalomyelitis/chronic fatigue syndrome, along with Gulf War illness and post-acute sequelae of COVID-19. He is an expert in neuroimaging, along with pain and fatigue disorders such as fibromyalgia and chronic fatigue syndrome. He has published over 100 peer-reviewed articles and book chapters on these topics and has received prominent awards on his research and teaching. Dr. Walitt will present Exploring the Post-Acute Sequelae of COVID-19 at the National Institutes of Health. Dr. Walitt, the floor is yours.
Hello, everybody. As I said in my talk today, is exploring the post-acute sequelae of COVID-19 at the NIH. Today, there's been a lot of talk about this particular virus, and I think everybody has their own stories about SARS-CoV-2. When SARS-CoV-2 first came about, I was the acting clinical director of one of the institutes at NIH, and I was privy to all of the conversations that were going on at the very beginning. And I realized right away that it was going to be a giant pandemic, that there was no way that it was going to be contained. And I knew right away that there would be long COVID because my career has been spent studying the post-infectious complications such as chronic fatigue syndrome. And it turned out that, yes, there was long COVID. People are using the term post-acute sequelae of COVID-19, sort of that scientific or medical term that's being used, and is defined as ongoing relapsing or new symptoms or conditions present 30 or days more after an infection. And this 30-day thing will come up again. And so at the very beginning, I was thinking, what are the main physiological mechanisms that are going to lead to PASC? And so we wrote a paper called A Clinical Primer for the Expected and Potential Post-COVID-19 Syndromes early on in the pandemic, sort of to guess at what we're going to see. You could take a look at this paper and you could tell me how I did. What we did think is that there would be three main arms that would lead to the long COVID issues that we're seeing today. The first being inflammation. It's pretty clear that active SARS-CoV-2 will trigger inflammation that's severe enough to cause tissue injury, and that some of this inflammation can persist even after the acute infection resolves. And there are multiple mechanisms that this can work through: alterations in the innate immune response with excessive monocyte macrophage activation or excessive inflammasome activation. And we know that there is a systemic immune response, and that has been shown with systemic cytokine imbalances and the cytokine storm. And there's also been evidence of adaptive immunity failure. Third, immune regulation and restoration issues could certainly play a role with persistent COVID-19 independent inflammation, development of autoimmunity. And we see this in a lot of kids with the MIS-C syndrome, which is a lot like Kawasaki's. And then there is the issue of potential of persistent viral reservoirs or persistent viral antigen. It is known that some viruses can, over time, assemble themselves, but not completely, like we see with measles. And the possibility that there could be some issues from persistent bits and pieces of virus leading to problems had to be considered. The second major arm was going to be thrombosis. SARS-CoV-2 can directly trigger thrombosis. Its target on the ACE2 receptor can create direct endothelial injury that we saw. And we know that any thrombosis is going to have lasting complications. Ischemic injuries are well described in medicine and have a long course of resolution. Besides direct endothelial injury, inflammatory activation and clotting cascades, inflammation and clotting are linked together biologically. And so you can't escape clotting if you have inflammation. Usually there is something called tissue factor. Complement activation is another potential way to create thrombosis, again, linking the immune system to the thrombotic system. And then it's been well shown that infections can create antiphospholipid antibodies, which are antibodies that stimulate clotting as well. Usually these are transitory, but it's possible that some of these may persist for long periods of time. Lastly, we knew that there would be fear, stress, and change from the pandemic. And this is something that we've all been experienced. All of us have been physiologically impacted by the unknowns and the alterations in our lifestyles that happened during the pandemic. And all of us, whether we like to admit it or not, are probably more vulnerable to chronic illness for what we went through. Fear, stress, and change, how it works on us is not 100% clear, but we know that there are a host of physiological effects that come with it, including effects in the endocrine system, on the hypothalamic pituitary axis, neurologic effects on the autonomic nervous system, immunologic effects, usually in the regulation of Th1 and Th2 homeostasis. And then for those who get really sick, there are a bunch of stress-related illnesses. Critical illness and post-ICU stress disorders are well documented. Stress is related to cardiovascular disease, asthma, dysautonomia, and other neuropsychological illnesses. And so we posited that there would be PASC subtypes or long COVID subtypes. There would be a cardiac subtype that was a consequence of cardiac disease, such as myocarditis, pericarditis, the complications of infarctions and heart attacks and arrhythmias. That there would be a pulmonary subtype that would be the consequence of pneumonitis, pleuritis, again, infarctions or reactive bronchoconstriction. And then there would be a neurologic subtype. And there were different ways that this could occur, either through direct neuronal inflammation and the complications of infarction and injury on nerve tissue. There would be a second wave of neurologic issues, including dysautonomia, movement disorders, headache disorders, and neurocognitive disorders that could follow. And lastly, there would be the post-viral fatigue syndrome, which is also known elsewhere as myalgic encephalomyelitis and chronic fatigue syndrome and fibromyalgia. The thing to keep in mind is that while these all have different mechanisms and underlying pathophysiologies, all of them can look the same from a clinical phenotype. If you talk to folks with any of these, they can all tell you about their pain, their fatigue, their exercise intolerance, their weakness, their alterations in sensation, altered cognition, and alterations in personality. Worse is that there's no reason why these have to be mutually exclusive, right? While people would like to think that they have one cause for it, there's no reason why people can't have more than one of these things at the same time. Not everybody is familiar with post-viral fatiguing syndromes, and I knew that this would be a major issue after COVID. Initially described in 1985 by Behan, he described the principal symptom as severe muscle fatigability, but a range of secondary symptoms such as the aching of muscles, disequilibrium, and psychiatric manifestation. And this has been studied epidemiologically in other infections. The UK viral meningitis study in '96 showed that with the 24 months, your chronic fatigue syndrome prevalence was around 12.6%. In Australia, the Dubo study in 2006 showed that, here you can see the rates, right after infection, about 35% of people would meet the chronic fatigue syndrome criteria, and about at 1 year, around 9%, where you can see that sort of drop off over time. SARS, which is certainly a close relative of COVID-19, also showed the same sort of pattern where about 27% of survivors after 40 months still met criteria for chronic fatigue syndrome. For those of you who are not familiar with chronic fatigue syndrome, you'll see here is a picture from one of my research participants. And all of the symptoms that have been talked about in all of the prior talks fit into the rubric of chronic fatigue syndrome. And so history strongly suggested that this was going to be a big problem. And it was. And here's from the New York Times back in 2021, what if you never got better from COVID-19? And here's from the first study done from Patient Advocate Survivor Corps back in 2020, which looked at online surveys of people who have problems after COVID. And you can see the most common problems here: fatigue, muscle and body aches, shortness of breath, difficulty concentrating, inability to exercise, headaches, difficulty sleeping, anxiety, memory problems, and dizziness. All of these are essentially in the criteria for myalgic encephalomyelitis, not fatigue syndrome. However, when one looks at the diagnosis, you can't make a diagnosis of ME/CFS until you're 6 months out. Right? So PASC is 30 days, but chronic fatigue syndrome is 6 months. And so you have this issue of time that you always have to keep in mind. So with all of that in mind, we created a protocol here at the NIH, the Natural History of COVID-19 Convalescence at the NIH. And there are a variety of phases, and I will briefly touch on 2 of the phases. The first phase A was a sort of an epidemiological survey using phone interviews and online questionnaires to observe and describe the range of medical syndromes that occur in the wake of SARS-CoV-2. And phase B was a 5-day inpatient evaluation of people having complications from SARS-CoV-2. And so in the phase A study, we were open since 2020, October, and we did these procedures. And this is sort of a heat map of 244 participants that filled out questionnaires for us. On the x-axis is how long out they were from their infection when they filled out our questionnaires. You can see from 0 to 3, 4 to 6, 7 to 9, 10 to 12, and over 12 months. And this is just the number of people saying they have this symptom when we talk to them. And you can see as you go deeper and deeper in the list, it gets more and more red as you go to the right. And if you look closer at that, what you see is as the longer out you are from your infection, the more likely you are to complain of dizziness, weakness, joint pain, shortness of breath, myalgias, headaches, sleep issues, concentration issues, word finding issues, and fatigue. So all the symptoms that one would see with chronic fatigue syndrome. The longer you go out, the more likely this long COVID looks like ME/CFS. And so we started bringing patients in for our phase B evaluations. And this was an evaluation designed to take my judgment out of their evaluation. And so we did an unbiased series of measurements on people that looked at their cardiac, pulmonary, and neurologic status. And here are the different procedures that we performed. And now I'm going to quickly go over 2 cases for you to give you a sense of what we see when we look at long COVID. And so the first case is a medical student, a 36-year-old Indian Asian male who was fully vaccinated and boosted prior to getting infected in December 2021, where he had what sounds like a pretty typical course of acute COVID. After 2 weeks, he continued to have some acute problems with fatigue that he noticed was worse after eating, some exercise intolerance, and the development of new cognitive issues, and particularly with word finding and short-term memory. As 3 months passed, things continued to get worse, not better. New dizziness, sleep issues, numbness and tingling in his hands and feet, and muscle twitching. And by May of 2022, he could no longer continue in his studies and had to take a leave of absence from medical school and went to a long COVID clinic and ended up with a long COVID diagnosis. After 6 months, he came to us for his evaluation. On exam, he was pretty unremarkable. There was nothing in his labs or his EKG, his echocardiogram. He had a stress test that he reached 16.1 METs and performed at 104% of what we predicted him to perform at. There was a mild defect in his pulmonary function testing that didn't seem too striking to us at the time. But we do CT angiograms on all people that come through because of the possibility of thrombosis. And I was amazingly surprised that this guy 6 months out had a number of persistent pulmonary emboli. On the right, you can see that big wedge of red. That is a pulmonary embolus highlighted with iodine radiography techniques that we have here at NIH. I would never have guessed in a million years that this person had a PE. And so we put him on apixaban anticoagulation for 3 months, and quickly he noted around a 90% improvement in his cognitive symptoms. But even though he improved pretty quickly, he didn't improve all the way. And his fatigue continued to linger on for up to a year. It took him 15 months after his infection to return to medical school as a 3rd-year student. And so even though there was a very quick improvement with treatment, it didn't just turn it all off. And this makes a very important point that one has to keep in mind when dealing with long COVID, is that a substantial number of these cases will have an alternate medical explanation rather than just long COVID. Sometimes the clinical presentations will defy expectations, and so clinicians won't look. Some of these folks will have a new diagnosis that is unrelated to COVID. Things happen as we get older, and some of them may be problems that are accelerated by the infection, such as people who are on their way to dementia and then have that process accelerated by being infected. And like this person, some people will have legacy effects of injury related to the SARS-CoV-2 infection, like pulmonary embolism or heart attacks or strokes. And so after review of 16 cases that have come through, we found a whole bunch of different things in our patients, all diagnosed in the outside with long COVID. One pulmonary embolus, 4 cases of newly diagnosed sleep apnea, 1 undiagnosed asthma that totally improved with treatment, 1 case of frontotemporal atrophy, 2 cases of increased intracranial hypertension on lumbar punctures, 2 other cases where there's evidence that the blood-brain barrier has been disrupted by COVID infection, 1 participant who was substantially deconditioned and developed non-alcoholic steatohepatitis, most likely to lifestyle changes during COVID rather than its infection, 1 case of Ehlers-Danlos syndrome, and 1 person with a functional movement disorder who fully recovered after about 5 months. Diligence and follow-up over time is going to be very important in understanding the causality of about 1/3 of cases in the past. Second case here. And this is the young scientist. This is a 23-year-old non-Hispanic white woman who was working as a scientific researcher who was also fully vaccinated and boosted prior to getting sick. She got infected in November of 2021 and had a pretty classic course initially, but it did get worse and led to a diagnosis of bronchitis requiring a prednisone taper and Advair. Over the next 2 months after her initial infection, she had a gradual improvement with some residual fatigue, some lightheadedness, some chest pain, some shortness of breath, and changes in her smell and taste. But 7 months in, there was escalation of her symptoms. Around that time, she had a summer cold and was participating in an aerobic exercise training regimen. And things just got really bad for her, where the fatigue became profound. She developed episodes of dizziness with tachycardia, shortness of breath, new cognitive issues, weakness and leg pain, sore throat, persistence, headaches, tinnitus, and sleeping issues. And then these didn't get any better. And she required accommodations at work. She started using a wheelchair for distance travel, got a diagnosis of long COVID, and came to us around 20 months after for an evaluation. She was pretty healthy, ostensibly with the normal vital signs and unremarkable physical examination, normal LAMS, a normal lumbar puncture, normal brain MRI, normal EKG, normal electrocardiogram, again, some mildly abnormal PFTs that presented some air trapping from the way that she breathed, nothing on her chest CT. When we exercised her, she had a submaximal test. She had to stop at about 81% of what she should be doing as a young lady. But what was notable about her is about 24 hours after we did the exercise stress test, she was all laid out for the next 40 hours. She just demonstrated something called post-exertional malaise. And so we were able to see that firsthand. We also sent her for a tilt table test and autonomic testing, and she had an increase in her heart rate on tilt that increased 66 from her baseline measure. All right, so she was very strongly positive for the postural orthostatic tachycardia syndrome, or POTS. So what is this young person's diagnosis? One could argue that she would meet all the criteria for chronic fatigue syndrome. Right, she has all of the symptoms, a substantial decrease in function, been persisting more than 6 months. She has post-exertional malaise and unrefreshing sleep, and there's cognitive impairment and orthostatic intolerance. So she checks all the boxes. However, she also would meet the criteria for post-infectious postural orthostatic tachycardia syndrome, where we show that she had a sustained heart rate increment of more than 30 within 10 minutes on a tilt table test. There was no orthostatic hypotension. There were frequent symptoms of orthostatic intolerance, more than 3 months. Again, time is playing with us, and the absence of anything else that explained it. And when you read about POTS, you'll see that 20 to 50% of POTS patients have an antecedent infection, although those are mostly in review papers. The epidemiological data to demonstrate this is pretty poor. What we do know is that SARS-CoV-2 and SARS-CoV-2 vaccines have been associated with the development of POTS. I point to this paper in Nature Cardiovascular Research, which looked at 12,000 patients, and the odds of developing POTS after infection was 1.5 compared to those who don't. However, it's important to keep in mind that this increase in POTS after SARS-CoV-2 isn't very different than what you would see in the population prior to the pandemic. It suggests that while you see an increase in POTS after infection, the giant increase we're seeing has more to do with the epidemiological size of the pandemic, as opposed to something unique about SARS-CoV-2. It looks like all infections have the possibility of doing this. I'm looking at our past participants. 4 of them met POTS criteria, and 1 of them met neurogenic hypotension. So it's certainly a frequent finding, even amongst our participants. The third possibility to think about, if this happened prior to the pandemic, I would have said for sure this looks like the post-Epstein-Barr viral fatigue syndrome, where young people get Epstein-Barr and they're laid up for months and months afterwards. And there's a lot of evidence to show that part of the way that MECFS got its origins may be through its relationship to EBV, and that EBV has also been implicated in POTS. And so this study from Cell in 2022, which is well known for showing the 4 risk factors for developing long COVID, one of those risk factors was EBV viremia. And while I won't go through this figure, you guys can look at that afterwards in the recorded findings. What's important to know is that in people who had more likelihood for developing long COVID, they had EBV viremia right at the time that they were acutely ill. So at the time that they were first tested for COVID, at the very beginning of their COVID infection, you were able to demonstrate Epstein-Barr virus being active in their blood. If you waited a week after that point in time where they were still acutely ill, but not immediately ill, that EBV viremia could not be detected, and it couldn't be detected 2 to 3 months later. The idea that EBV reactivation is happening really early in SARS-CoV-2 infections is a fascinating idea, and it's something to keep in mind when trying to understand what long COVID is. It's also something that is only able to be seen at the moment it's happening. So what about this person? What are we supposed to say? Well, this past case doesn't have a good alternative medical explanation outside of what I've put forward. There are no noted medical conditions that appear to account for the entire clinical picture. She does meet the descriptive criteria for MECFS, but MECFS doesn't really suggest any particular treatment. She also meets all the objective criteria for POTS, which suggests taking a POTS treatment approach, which she had been prescribed and really didn't make much of a difference in her overall function. We did look also into EBV reactivation. We didn't see any EBV in her serum. She had definite prior exposure, but we couldn't demonstrate anything going on right now. Cases like this emphasize the difficulties that of past categorization. Because this person could have 3 different entities, it's going to confound how we label such cases and will confound our ability to do research in long COVID. In conclusion, past represents a wide range of medical complications. These can be cardiovascular, pulmonary, or neurologic injuries. Often the legacy effects from injuries from the infection itself. It can also represent coincidental or accelerated medical events that are unrelated to SARS-CoV-2. And it can also represent the post-viral fatiguing syndrome, which is not unique to SARS-CoV-2. Post-viral fatiguing syndromes are common. It seems pretty similar here that we see in other infections. And again, time is going to be important in distinguishing this from other past subtypes. Biology of underlying post-viral fatiguing syndromes is not known. Case heterogeneity will complicate our ability to do research. And this is a fascinating area and a unique opportunity to understand more. And our group here plans on continuing our work to try to get at this underlying biology. I'd like to thank and acknowledge all the people on this slide who have worked with me in getting our clinical enterprise up and running and our research enterprise up and running. Thank you so much for your attention.
Well, thank you so much for an excellent presentation on SARS-CoV-2 and long COVID. Needless to say, as all the other speakers have also emphasized, this is a problem that we're still searching for a good solution to. And the best solution right now is the prevention of getting sick with COVID-19.